Well, welcome to Fetal Board. We've got the OB team here. Dr. Vu and Dr. Beernal will present chorioamnionitis.
Hi everybody, I'm Dr. Vu. I'm a PGY3. We're going to talk about chorioamnionitis today. It's one of our most common infections that we diagnose on the labor unit, and we just wanted to kind of talk a little bit more about it in depth and see what the peds side was, and as well as neonatal outcomes. So by definition, chorio is an inflammatory response in tissues of the either fetal maternal space, like in the choriodeciduous space. I don't know if I can do it. Oh, there. Around here. Or it could be of fetal origin in the chorioamniotic membranes, the amniotic fluid, or the umbilical cord itself. The incidence has been widely, varies widely among publications, but there is one common trend that with increasing gestational age, there is decreased incidence of chorioamnionitis. And so as you can see, quoted less than 27 weeks, your risk of chorio is 41%. At 28 to 36 weeks, gestational age, your risk is 25, and term is around 2 to 4. A third of our preterm labors with intact membranes have been diagnosed with chorio, and in women who come in with preterm premature rupture of membranes, 40% of them have chorio, and once they're admitted and then they develop preterm premature rupture of membranes, about 75% of those are diagnosed with chorioamnionitis. The fetal inflammatory response is the activation or the response in the fetus to the inflammation in the mom. It can result in systemic injuries and major adverse neonatal outcomes. Usually they diagnose that by either they can detect interleukin-6 in the cord blood, or histologically by infection of the umbilical cord, or phonocytis, or choriovasculitis.
So my name is Ileana Beernal. I'm going to present one of the patients that we had up in our labor unit about a month ago. Her name is Miss JW. She's a 16-year-old African-American female, G1P0, at 38 weeks and 0 days by a 9-week ultrasound. She presented to labor unit around 2 o'clock in the morning on October 22nd, complaining of leakage of fluid at approximately midnight, as well as pelvic pressure. She endorsed positive fetal movement, denied vaginal bleeding, vaginal discharge, pre-E review of systems or any contractions. Her past medical history was non-contributory. Her vitals upon arrival were within normal limits. Her physical exam was significant for positive pooling with and without Valsalva, positive nitrazine, and positive ferning. Oh, this thing. On exam, she was noted to be 1 thick and high. Her prenatal labs were within normal limits. She was admitted to our service for augmentation of labor. She was given Cytotec and a Foley bulb at around 2:45 in the morning. Around 4:30, the Foley bulb came out. We did a cervical exam. She was noted to be 450 and -3 at that time. Her NST was a category 1, and she was contracting about every 2 to 3 minutes. Then it was noted approximately 1300 that she had an elevated temperature of 103.2 and a pulse of 111. NST showed a baseline of 160 with moderate variability, occasional early D cells, and a category 1 tracing. She was again still contracting every 2 to 3 minutes. Cervical exam noted her to be 575 and -2. At that time, she was started on ampicillin, 2 grams IV, and a 120 milligram bolus of gentamicin. The patient was counseled at this time about the risk of a C-section if she failed to progress or if there was fetal intolerance to labor. She understood at that time and agreed. At around 1800, she spiked another temp of 102.4, and then again at 1900, 103.1 and a pulse of 107. Her cervical check was still about 5 to 6, 90 and -2. And her NST noted, as you can see, she had about 2 late decelerations at 1916 and another one at 1920, and then again at 2004 and 2008. So at about 2000, it was decided to proceed with primary C-section due to non-reassuring fetal heart tones remote from delivery. She was taken to the operating room at around 2200 for a primary load transverse uterine hysterotomy. And she delivered a viable male infant that weighed approximately 6 pounds, 1.2 ounces with APGARs of 8 and 9. The baby was taken to the nursery. Post-operative day 1 was significant. She was noted to have a temperature of 100.4, which resolved with Tylenol. She didn't have any other temperatures after that. The incision was noted to be clean with minimal bleeding. She was given 3 grams of Unison once post-op. Her post-operative day number 2 was uncomplicated. She was afebrile during that whole time, and she was discharged on the 25th of October in stable condition. She returned 3 days later to acute clinic for a staple removal. Her wound was noted to be intact and healing well without signs of infection. The staples were removed at that time, and she was instructed to return again to us in 5 weeks for her postpartum visit.
So now we'll go on to talk about what happened to the baby. So the male infant was born at 2241 with APGARs of 8 and 9. The rectal temperature done at that time after being moved to the newborn nursery was 100.2. Because the mom had choreo diagnosis, the baby had labs drawn for CVC with differential that was within normal limits. Her CRP was less than 2.9, and then blood cultures were drawn, and the baby was empirically started on ampicillin and gentamicin. On 10/24, with daily labs, the CVC continued to be within normal limits with a low CRP, and blood cultures showed no growth for 3 days, and at that point, the baby antibiotics were stopped and the baby was discharged home. So the major risk factors for early onset neonatal sepsis is, of course, preterm birth, maternal GBS, ruptured membranes greater than 18 hours, and the maternal intraamniotic infection or chorioamnionitis. Signs of sepsis in the neonates can include poor feeding, fever, tachycardia, lethargy, and once the mom was diagnosed with chorioamnionitis, these are the limited evaluation that was done, and the empiric antibiotic therapy. This is the algorithm that he's used to manage to see if the baby has any signs of sepsis. Initially, if there is signs, then they undergo full diagnostic testing. If not, and the mom was diagnosed with chorio, then they would undergo a limited evaluation with antibiotic therapy like this baby did. If not, it undergoes this algorithm where if there was GBS prophylaxis indicated, and if the mom was GBS negative, then there would be no indication. But if yes, did she receive penicillin, ampicillin, or ANSEP for greater than 4 hours, which this then if yes, then just observation. If there's any signs of sepsis, then they would restart the antibiotic therapy. If not, if there was no antibiotics, then and the baby was over 37 weeks with the rupture of less than 8 hours, then they would have continued observation. And if not, then the baby was preterm or the rupture was greater than 18 hours, then they would do a limited evaluation and see if they would need to start antibiotic therapy.
Okay, I'm going to talk about maternal risk factors. The two most important are the first two, prolonged labor and prolonged membrane rupture. But the other risk factors include multiple digital vaginal exams, which may be just a confounder of prolonged labor. Nulliparity, if you've had a previous intraamniotic infection, you're at higher risk. Meconium stain amniotic fluid, instrumentation like FSC or IUPC, and then presence of genital tract pathogens, alcohol or tobacco use. So here's a chart with all of the risk factors on the previous slide and their relative risk for increasing the rate of infection with chorio. As you can see, with prolonged membrane rupture of greater than or equal to 12 hours, the relative risk of developing chorio goes up to 6. And then at 18 hours, 7. So not much difference between those two. With prolonged labor, the relative risk is about 4. And you see those have the highest numbers. The most common organisms that cause intraamniotic infection are listed above. Most chorio is polymicrobial, and if you culture a woman's amniotic fluid, they'll at least grow out like 2 different bugs. Mycoplasma and ureaplasma are really the most common. They are present in the genital tract about 70% of the time. GBS is another big one, and then gram-negative anaerobes. Those are more common in the preterm babies. So in order to diagnose chorio, you need a maternal fever of greater than or equal to 100.4, and this is the only criteria that you must have in order to make the diagnosis. And then besides the fever, you need one of the other 5. So maternal leukocytosis of greater than 15,000, maternal tachycardia, fetal tachycardia, uterine tenderness, or foul odor of the amniotic fluid. So the temperature guidelines is 38 degrees Fahrenheit. And so if you've got a temperature of 38 degrees Fahrenheit, that's greater than the 95th percentile, so that's definitely an abnormal value. Maternal heart rate of greater than 100 is used for the diagnosis of intraamniotic infection, and that reaches about the 90th percentile. Also the fetal heart rate of greater than 160, that's about the 90th percentile. And then a white cell count of 15,000, that's in the 80th percentile of normal values. Okay, so these are the symptoms of chorio and their frequency when there's actually an infection present. So fever has to be present 100% of the time. The most common is probably the leukocytosis, greater than 15,000 white blood cells, followed by fetal tachycardia, maternal tachycardia, uterine tenderness, and foul amniotic fluid are the least seen. So anytime you're thinking about diagnosing chorio, not only do you have to have the fever, but also the other symptoms. The problem is the other symptoms could be caused by other normal things. So labor can cause leukocytosis, tachycardia, uterine tenderness, and fever, especially if there's an epidural in place. The risk of having a fever with epidural is 3.34, and this is caused by the sympathetic blockade. You don't have the perspiration to let off heat. Also, the mom's hyperventilation is decreased in response to pain. They also think that there's a thermal dysregulation just due to being pregnant, and then there could be a inflammatory response in the placenta or in the epidural space from having the epidural placed, which all could cause a fever. Another differential would be abruption. This can cause uterine tenderness and tachycardia, but usually you will not have fever with this. And then extra uterine infections can cause fever, abdominal pain, so think about your pyelo, some pneumonias, influenza. So if you are unsure about the diagnosis, an amniocentesis is actually the gold standard for diagnosis. However, it's limited because the results take a couple days to come back, and by then the patient's hopefully already delivered. So most of the time when an amniocentesis is done, culture amniotic fluid, it's for patients with pre-prom or preterm labor. So people who have PPROM, preterm premature rupture of membranes, if they have any sign or signs of chorio, then that's an indication for induction. So to confirm that diagnosis, sometimes amniotic fluid culture can be done, and then if the culture is positive, then they can be induced. Another reason you would use that maybe with a patient who's in preterm labor and it's persistent despite tocolytics, and you want to know if there's any other reasons to why they're in preterm labor. It's not very clinically useful in terms of a patient who's in labor and you're suspecting chorio. A gram stain of the amniotic fluid, checking the glucose, the white blood cell concentration, and the leukocyte esterase can also be done, and these are like a lot quicker tests that you'll get the results from a lot faster. But the test isn't a very good one. You'll have a lot of false positives, and the positive predictive value isn't very good. So we don't really use it that much.
So once you've established the diagnosis of chorio, immediate initiation of broad-spectrum antibiotic that cover beta-lactamase producing aerobes and anaerobes is indicated. Gibbs has done large studies on chorio, extensive studies, and he's referenced in Creasy and Gabby, Williams, all of those books. This is one of his studies in addition to a study by Spearling and Gilstrap that showed antepartum antibiotics decrease the risk of neonatal sepsis up to 4-fold, and it also increases maternal outcome like their duration of fever or duration of hospitalization as opposed to starting antibiotics postpartum. The most extensively studied regimen is ampicillin and gentamicin, 2 grams IV Q6 and gent 1.5 mg per kg IV Q8 hours because those target the most likely causative agent of neonatal infections, GBS and E. coli. They're also readily available, they're generic, and they're inexpensive. There are more recent studies that look at gentamicin once daily dosing at 5 mg per kg in patients who have normal renal status. It's shown to be equally effective without increased maternal or neonatal toxicity, and also shows an increased fetal level as opposed to the TID dosing. If you, other regimens like extended spectrum penicillins, Unison, or cephalosporins like Mefoxen have also been studied but less extensively, and they're also likely to be more expensive. There's a treatment failure rate with abdominal delivery up to 20 to 30% with just ampicillin and gentamicin alone, so anaerobic coverage with clindamycin is necessary, which you add 900 milligrams IV after cord clamping. An alternative is Flagyl 500 milligrams IV once. With penicillin allergic patients, you want to use clindamycin, and if immunocompromised, amikacin is the agent of choice because they're likely to be affected with highly virulent pathogens that are resistant to and they're gram-negative anaerobic bacilli. So there's limited data that exists regarding the optimal duration of antibiotics. One study by Edwards and Duff showed an additional 1 dose of IV AMP and Gent is sufficient treatment. Some clinicians do like to continue until the patient's afebrile or asymptomatic for 24 hours. However, this study showed no benefit to that. Oral antibiotics are not beneficial post-parenteral therapy. Continuous fetal monitoring is obviously indicated for anybody who's in labor, but it's also necessary to assess fetal well-being. Up to 75% of patients with chorio will have some fetal heart rate abnormalities like either tachycardia or decreased fetal variability. Maternal fever and fetal acidosis are independent risk factors for neonatal encephalopathy, therefore antipyretics are recommended. Ultimately, delivery is the cure, and it's an indication once the diagnosis is made. There's no critical interval from diagnosis to delivery, and C-section should be reserved for standard obstetric indications. Gibbs did another study and found that the mean time to diagnosis to delivery was between 3 to 5 hours, and that more than 90% of patients were delivered by 12 hours. Those who delivered vaginally had lower rates of adverse maternal outcomes, and again, there's no evidence that the duration of labor correlates with adverse neonatal outcomes. So since 1979, the systematically collected data has shown excellent maternal outcomes with no deaths in mothers who receive appropriate treatment. Inflammation can lead to impaired myometrial contractility and labor abnormalities, and up to 75% require oxytocin for augmentation. Subsequently, cesarean rates are increased 2 to 3-fold, typically because of inadequate uterine response to oxytocin or abnormal progression of labor. Additionally, uterine atony can cause issues with postpartum hemorrhage. Bacteremia complicates 3 to 12% of infected women, and when C-section is required, wound infection develops in up to 8%. 1% develop a pelvic abscess. Venous seeding of infection can lead to endothelial damage and stimulate pelvic thrombosis. In less than 1%, the incidence is 1 in 175 in patients who undergo a C-section with chorio, as opposed to 1 in 2,000 in the general population. So again, septic shock is less common, and maternal death is even more rare than that.
So now we'll talk a little bit about the neonatal outcomes and what happens to these babies who are diagnosed with chorio, receive appropriate antibiotics. So in terms of as a preempt to this, there's a lot of confounding data out there on neonatal outcomes, especially when you adjust for prematurity as an increased risk for these outcomes. It gets confounded. There are articles for certain diagnoses, and then there are articles that couldn't find any statistical significance. So one of the most mentioned ones are the risk of respiratory distress in premature infants, and they found that that's an independent risk factor where 34% versus 16% of these babies develop the RDS. And the idea behind this is that the severe infection causes damage to the alveolar capillary unit in the lungs, and causes the lungs to have a looser hold, and more inflammatory cells can go into the lungs, causing inactivation of surfactant and producing poor response to any substitution surfactant. So that's why babies that have severe RDS who are diagnosed with severe RDS, they don't respond well to the surfactant that they give postpartum. So there's a difference between clinical chorio and histologic chorio. As we talked about, Dr. Bunton talked about the diagnosis for clinical chorio. And histologic chorio is dependent on microscopic evidence of inflammation, such as the presence of inflammatory markers like macrophages, T cells, and in that it represents the manifestation of either local or systemic inflammation. So a lot of times women can be diagnosed with histologic chorio and not the clinical, because they don't develop the fever, the leukocytosis, the foul discharge, the abdominal pain. So the counterintuitive respiratory outcome, they mention bronchopulmonary dysplasia, which is a lung disease where it's characterized by both pulmonary angiogenesis and alveologenesis, and causes inflammation and scarring. These babies have decreased lung volumes and atelectasis and hyperinflation, and you can see there's like haziness seen on this chest x-ray. What is noted about bronchopulmonary dysplasia is that RDS seems to play beneficial effect, but it increases your risk of BPD because the idea is that choreo leads to the stimulation of the adrenal glands, which releases cortisol and accelerates the maturity of these lungs, but the quickened maturation causes a distortion in the structural lung development. So Dempsey looked at the short-term outcomes of newborns less than 30 weeks. He had 392 neonates, and he found that there was a significant reduction in respiratory distress because of the accelerated maturation. And Hartling, he did a meta-analysis of 59 studies in these infants, and he found that the odds ratio of developing PPD after choreo was 1.89. So sepsis. The incidence of sepsis in low birth weight infants less than 2,500 grams is about 16%. And if they're greater than 2,500 grams, it's about 1.4. Preterm infants usually have a 2 to 10 increased risk of early onset sepsis. And the idea that histological choreo has an increase in risk of early onset sepsis, but it helps them prevent the development of late onset sepsis, which is defined as development of infection after 72 hours of birth. It seems like the inflammation helps mature the immune system of the neonates and helps them protect against the late onset sepsis. And so Stunk, he did a study where he looked at 830 preterm infants, again less than 30 weeks of gestation, and he found that the odds ratio of developing early onset sepsis was 2.3, but it decreased risk of late onset sepsis with a hazard ratio of 0.74. So when it comes to brain injury and neurological outcomes, there's conflicting data between like intraventricular hemorrhage grade 3 and 4, if there's cognitive delays and neurological deficits. But most of the neurological deficits, I think, can be based off of the development of cerebral palsy because clinical and histological choreo has been linked to it, as well as the cystic periventricular leukomalacia in both term and preterm infants. So cerebral palsy is the impairment of posture and motor function. It's non-progressive, it's multifactorial and heterogeneous. They have a lot of different presentations. And cystic periventricular leukomalacia is a type of brain injury that affects preterm infants commonly. It involves like death of small areas around the ventricles. So here's a picture of that. And the major cause of it is thought to be like changes into the flow to the area of the ventricles. And so they have a lot of theories of how choreo can cause neurological effects, meaning that the inflammatory factors from the go in, damage the blood-brain barrier, causes more protein to cause damage to the white gray matter. And there's also, like, there could be an interruption of the gas exchange and blood flow, resulting in hypoxic ischemic brain injury. The maternal fever can also cause, like, fetal core temperature elevations or the infection of the fetal brain itself or the meninges. And it's more common, and it develops in a population that's already predisposed to it in these very preterm infants who are low birth weight. Wu et al. And did a systematic review, and I'll show you a little bit later in a chart, where he found the increased risks to be 140% and 80% for neonates with clinical choreo or histological choreo. So once the clinical has a much greater risk of developing cerebral palsy. Shatrov also did another study on clinical chorioamnionitis and found that there was a odds ratio of 2.4% in developing it, and for histological there was 1.3%. So this is a table that's put together. It's a meta-analysis of the chorioamnionitis as a risk factor for cerebral palsy and periventricular leukomalacia. It combines the data from Gretner and Wu's meta-analysis, and as you can see that clinical chorio always has a greater risk of developing cerebral palsy and cystic periventricular leukomalacia in preterm infants. And in term infants, the diagnosis of chorio increases risk to 4.7 versus histological is 1.6. In terms of neonatal mortality, usually whenever chorio confers a risk of 1.4% mortality in term infants, and in preterm infants, it's about 10%. Those were the major neonatal outcomes that were discussed in the literature review. And so, like I said, there is a lot of confounding articles and literatures and research regarding the outcomes of these children, because the fact that they're so premature and they're already at risk of developing all of these outcomes already, and the question of whether chorio increases their risk gets confounded. Questions?
What is the incidence of histological chorio versus clinical chorio?
I don't know the answer to that, but I feel like there is a higher incidence of it, because a lot of our placentas that are sent off for IUGR or just abnormal growth, they come back with histological chorio diagnosed on there, and we never diagnose it clinically.
It's not diagnosed histologically.
So is it more common histologically or
More common clinically.
But I'm pretty sure there's some studies that have been done that just sent placentas cured, and they were looking for non-clinical indications to find the percent of histological chorio that's present.